What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my endocrinology playlist. In previous videos, we talked about the pituitary gland, anterior and posterior. We talked about the hypothalamus, the thyroid gland, the parathyroid glands, adrenal cortex, adrenal medulla, the endocrine pancreas, the gonads, etc. We talked about the hormones such as GHRH, CRH, TRH, GnRH, growth hormone, prolactin, TSH, ACTH, FSH, LH, ADH, and oxytocin. We also talked about the hormones that come out of the thyroid gland, including T4 and T3. T4 is more abundant, whereas T3 is more potent. In today's video, we shall talk about radioactive iodine. We can use it diagnostically, and we can use it therapeutically. Click the like button, click the subscribe button, and let's get started. This video was made possible thanks to a generous donation from Stuart. Please take a moment to thank him in the comments. Thank you, sir, for your support. This video is part of my endocrinology playlist. Please watch these videos in order for maximum understanding and retention. If you have watched my thyroid hormone video in my physiology playlist, you shall recall that we have a chief executive officer, the CEO, which is your hypothalamus, followed by a general manager, which is your anterior pituitary, then a bunch of employees. When the hypothalamus secretes growth hormone releasing hormone, the general manager responds by secreting growth hormone, also known as somatotropin, which makes your body grow somatotropin. Growth hormone is going to reach the liver and ask the liver to make IGF-1. Next, when the hypothalamus secretes somatostatin, the opposite happens. Somatostatin is going to inhibit growth hormone secretion. If the hypothalamus secretes gonadotropin-releasing hormone, the anterior pituitary responds by making LH and FSH, known as the gonadotropins. The luteinizing hormone and the follicle-stimulating hormone will target the gonads. In males, the gonads are the testes, and they are going to make testosterone and dihydrotestosterone. In females, the gonads are the ovaries, and they're going to produce estrogens and progesterone. Next, when the hypothalamus secretes TRH, the anterior pituitary responds by making TSH. This is thyrotropin-releasing hormone. This is thyrotropin itself, otherwise known as thyroid-stimulating hormone. Why do we call it thyroid-stimulating hormone? Because it's a hormone that stimulates the thyroid gland, namely the thyrocytes that line the follicles of the thyroid gland. When the thyroid gland responds to TSH, it shall secrete T3 and T4, thyroid hormones. We are not done yet. When the hypothalamus secretes CRH, or corticotropin-releasing hormone, the anterior pituitary responds by making corticotropin, also known as ACTH, which is adrenocorticotropic hormone, which is a hormone that targets the cortex of the adrenal gland. The cortex of the adrenal gland is going to make cortisol and adrenal androgens. When the hypothalamus makes the same TRH, anterior pituitary makes prolactin. But when the hypothalamus makes dopamine, the pituitary makes less prolactin. And of course, prolactin is prolactation because it helps secrete milk from the mammary glands. The hypothalamus can also make antidiuretic hormone, which is stored in the posterior pituitary. The function of ADH is to raise your blood pressure, basically by constricting vessels or by reabsorbing water from the kidney. As for oxytocin, another hormone made by the hypothalamus, it is the love and bonding hormone. It pushes milk out of the breast, it pushes the baby out during labor, and it pulls the sperm in during coitus. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. So again, when the hypothalamus makes thyrotropin-releasing hormone, the anterior pituitary responds by making thyroid-stimulating hormone. Then the thyroid-stimulating hormone is gonna flow throughout the bloodstream until it reaches the TSH receptor on the surface of the thyroid gland. The thyroid gland responds by making T4 and T3, the tetra and the tri, and these are thyroid hormones. Again, T4 is the more abundant, T3 is the more potent. Now we need to understand the phenomenon of negative feedback because this will be very important later in the video when we talk about how to monitor the treatment and the patient's response to the treatment. So let's say that for whatever reason, my thyroid gland went crazy and started making too much T3 and T4. Is this good for me? No. What should I do? I should try to do the opposite. I should try to decrease T3 and T4 back to normal. How do you do this? The hypothalamus will do the opposite by making less TRH. The anterior pituitary will therefore make less TSH. Eventually, we will decrease the level of T3 and T4, and this is called negative feedback. But what if the thyroid did the opposite? What if the thyroid started by decreasing T3 and T4? What should we do? The opposite. The hypothalamus makes more TRH and the pituitary makes more TSH. Eventually, the thyroid will raise its thyroid hormone secretion level back to normal. And this is the story of negative feedback. If you wish to see more videos like this in the future, drop your favorite food emoji in the comments. Where do we find the thyroid gland? It's located in the anterior part of your neck, in front of the trachea or the windpipe. But let's take a look inside your thyroid gland. Inside your thyroid gland, we will find circles and circles and circles. Of course, this is a two-dimensional picture, but in reality, they are spheres. Each sphere is a follicle. This is a thyroid follicle, here's another thyroid follicle, and here's a third thyroid follicle. Between one follicle and the next follicle, we have parafollicular cells, which secrete calcitonin. But that's not the topic of today's video. To learn more about calcitonin, please refer to my physiology playlist. How about the thyroid follicle itself? The follicle has follicular cells, not to be confused with the parafollicular cells. These follicular cells are also known as the thyrocytes, and these are the cells that actually make the thyroid hormone T4 and T3, tetraiodothyronine and triiodothyronine. These follicular cells are surrounding the lumen. The lumen of the thyroid follicle, also known as the follicular lumen, is filled with colloid, and it has thyroglobulin. Please do not confuse thyroglobulin with thyroid binding globin, which is in the blood, which is different from thyroglobulin. So, in a nutshell, the follicular cells of the thyroid gland are going to make thyroid hormone, whereas the parafollicular cells will secrete calcitonin. Calcitonin from the parafollicular cells, whereas T4, T3, and reverse T3 are secreted by the follicular cells of the thyroid gland, also known as the thyrocytes. T4 is the most abundant, about 93%. T3 is the most potent, and it's less abundant, it's about 7%. Reverse T3 is the least abundant, which is less than 1%. Remember that the follicle has follicular cells surrounding a lumen. What's in the lumen? Colloid. What's in the colloid? Thyroglobulin. If it ends in IN, it's a protein or a peptide. Thyro because it's in the thyroid gland. Globulin because it's a globular protein. And we are going to make T3 and T4 within the substance of thyroglobulin. After that, you take the T4 and T3 away from the thyroglobulin and you secrete the T3 and T4 to the bloodstream. The bloodstream is going to take that thyroid hormone and distribute it all over the body so that the thyroid hormone may perform its physiological function, e.g. boosting metabolism. In order to make thyroid hormone, you need a carrier, that's thyroglobulin, and you need two raw materials contained within the thyroglobulin. The first raw material is iodine, and the second is tyrosine. Tyrosine is a building block not only for thyroid hormone, but also for dopamine, norepinephrine, and epinephrine, collectively known as the catecholamines. Now you understand why T4 is called tetraiodothyronine. Iodo because it needs iodine. You need to understand the difference between chloride and chlorine. Chloride is an anion, it's a negative ion. But chlorine is not an anion, it's not an ion, it's a molecule. Similarly, we have iodide and iodine. How do you lose the negative charge and become neutral? Well, a step up is called oxidation. So when iodide is oxidized, it becomes iodine. Where do you find iodide? I find it in the blood. Where do you find iodine? Inside the lumen of the follicle of the thyroid. So, how do you convert iodide to iodine? I need oxidation, therefore I need a thyroperoxidase to perform oxidation in the thyroid gland, thyroperoxidase. And this is the first step in the formation of thyroid hormone. What's the second step? Organification. What does that mean? You take this iodine, not iodide, and you're gonna make it attach to the thyroglobulin. The carrier? Yes, this is the carrier, thyroglobulin, and now I'm attaching the organic iodine to it. This is now organic, but the iodide is inorganic. You can put one iodine, now it's called monoiodotyrosine, because tyrosine is on the carrier as well. But what if you put two iodines? Now it's called diiodotyrosine. So step number 1 was oxidation. Step number 2 is organification. How about step number 3? That will be coupling. Coupling of what? Of mono and di. Mono 1 plus di 2 equals tri 3. Triiodothyronine, also known as T3. What if you couple a di with another di? That's a tetra. 4. Tetraiodothyronine. So therefore T3 has 3 iodines, whereas T4 has 4 iodines. It's oxidation, organification, and coupling. That's why iodine is very important for your thyroid gland. If you do not live near a sea or an ocean, it's a good idea to use iodized table salt. What is iodized table salt? Well, it has sodium chloride because it's salt, but it also has sodium iodide for your doozy thyroid gland. Now, let's say that you ingested some of this iodized salt. It is sodium iodide. Here's the sodium, here's the iodide. When you eat sodium iodide, it ends up in your stomach, then in the intestine, then it gets absorbed from gut to blood. Who's going to carry iodide in the bloodstream? The answer is albumin, a protein made by the liver. Now iodide is here in the blood that's near the follicle of the thyroid gland, and this is the cell that lines the follicle, also known as the follicular cell, otherwise known as the thyrocyte. It's an epithelial cell. Iodide is gonna pass through the membrane and enter into the gland, into the thyrocyte. Now, if you leave it as iodide, it can just leave. In the same manner of entry, it can simply leave. So what should I do? You need to trap it inside. How do I trap it inside? By quickly oxidating the iodide into iodine. All you need is 2 iodides, and then boom, you have iodine. And this helps with the concentration gradient, because if you leave the iodide as iodide, it will pile up here, and if it piles up here, it makes it harder for the iodide to enter, because now it's entering against concentration gradient. Therefore, by oxidizing the iodide into iodine, the concentration of iodide ions decreases compared to the high concentration of iodide ions in the blood, which creates a concentration gradient to help the iodide enter into the thyrocyte. Then what? Thyroperoxidase is going to help us with the oxidation. Now I have iodine. What's next? You need to put the iodine onto the carrier by a process known as organification. Who's the carrier? Thyroglobulin. What does it contain? Tyrosine, the famous amino acid that we studied in biochemistry. Please refer to my biochemistry playlist to learn more about the amino acids. After oxidation and organification, now it's time for coupling. If you couple the mono with the di, you get tri. If you couple a di with another di, you get a tetra. But the tri and the tetra are still bound to thyroglobulin, the carrier. Now, how can I liberate my thyroid hormone from the carrier? You need a protease to break down that protein. Protease is going to liberate your T3 and T4. You're going to secrete them from the thyroid gland to the blood, and then they're going to reach their target tissue, which is almost every tissue in your body, because thyroid hormone is very important, metabolically speaking. So again, it's oxidation, organification, and coupling. All of these 3 processes are aided by and stimulated by and catalyzed by thyroperoxidase enzyme. Now, let's talk about primary hyperthyroidism, secondary hyperthyroidism, and tertiary hyperthyroidism. What do all of these have in common? They are hyperthyroidism, meaning T3 and T4 have to be high. So, in primary hyperthyroidism, it means that the problem is in the thyroid gland itself. So the thyroid is going to make too much thyroid hormone, and when T3 and T4 are high, by negative feedback mechanisms, TRH will decrease from the hypothalamus and TSH will decrease from the pituitary. So when we see these labs, we know that the patient has primary hyperthyroidism. But what if it's secondary hyperthyroidism? It is hyperthyroidism, so therefore T3 and T4 have to be high. But it is secondary, meaning whose fault is this? It's the anterior pituitary's fault. The anterior pituitary made too much TSH, that's why the thyroid made too much T3 and T4, and by negative feedback, the hypothalamus will make less TRH. When you see this set of lab values, you know that your patient has secondary hyperthyroidism. How about tertiary hyperthyroidism? Well, the problem started in the hypothalamus. The hypothalamus made too much TRH, so the anterior pituitary responded by making too much TSH, and therefore the thyroid responded by making too much T3 and T4. How about hypothyroidism? We also have primary, secondary, and tertiary, and it's the same story. Primary hypothyroidism, the disease is in the thyroid. Secondary hypo, the problem is in the pituitary. Tertiary hypo, the problem is in the hypothalamus. Let's compare between hypothyroidism and hyperthyroidism. What are some causes of hypothyroidism? One is Hashimoto thyroiditis, which is an autoimmune disease, where we have nasty antibodies destroying my thyroid gland. I have a video titled Hashimoto thyroiditis in my endocrinology playlist. Thyroid gland ablation, destruction of the thyroid tissue. You can do this by surgery. You can do this by radioactive iodine. We're going to talk about radioactive iodine soon. Hypothyroidism could be blamed on the hypothalamus. We call this tertiary hypothyroidism. It could be blamed on the pituitary. We call this secondary hypothyroidism. Or it could be blamed on the thyroid gland itself. It could also be caused by the deficiency of the raw material iodine, or by toxicity from medications such as the nasty amiodarone, which is an antiarrhythmic medication. How about the causes of hyperthyroidism? We have Graves' disease. See my endocrinology playlist. Thyroid adenoma, which is a benign tumor in the thyroid gland. Toxic multinuodular goiter. Thyroiditis, see my endocrinology playlist. Iodine excess, blame it on the hypothalamus, blame it on the pituitary, blame it on the nasty amiodarone. What are the symptoms of hypothyroidism and the symptoms of hyperthyroidism? If you understand that the function of the thyroid hormone is to be metabolically active, then you can deduce the symptoms of hypo and hyper. In hyper, metabolism is so high, so active. In hypothyroidism, the metabolism is too weak and too lazy and too apathetic. So in hyperthyroidism, my heart rate goes up. In hypo, it's the opposite. It goes down. In hyperthyroidism, metabolism is so robust that I am intolerant to heat. I feel so hot. In hyperthyroidism, the bowel motility is off the chart. I get diarrhea. But in hypothyroidism, the bowel motility is almost non-existent. I develop constipation. In hyperthyroidism, I am nervous and sweating. In hypothyroidism, I'm lethargic, apathetic, and dry. In hyperthyroidism, because the metabolism is too active, I tend to lose weight. But in hypothyroidism, the metabolism is apathetic, so I gain weight. In hyperthyroidism, my deep tendon reflexes are heightened, but in hypothyroidism, they are diminished. How do you treat a patient with hyperthyroidism? We can do so by antithyroid medications such as propylthiouracil and methimazole. Propranolol can help in the thyroid storm, and then when everything fails, you can destroy the thyroid. We can do so by means of surgery or by means of radioactivity. How about the hypothyroidism? Give the patient what he lacks. If the patient lacks thyroid hormone, give the patient thyroid hormone, and you have two options. There is T4, levothyroxine, and T3, leiothyronine. In order to understand radioactive iodine, we need to review some chemistry. In my general chemistry playlist, I've talked about the atomic number and the atomic mass. For example, in sodium, the name of the element is sodium, the symbol is Na because in Latin it is natrium. Then there is a small number and a big number. The small number is the atomic number, the big number is the atomic mass. The atomic number is the number of protons, which happens to equal the number of electrons, whereas the mass number is the number of protons plus the number of neutrons. Here is the nucleus. The nucleus has neutrons, which are neutral, and protons, which are positive. Revolving around the nucleus, we have the electrons, which are always negative. The atomic number, which is the smaller number, is the number of protons, which happen to equals the number of electrons. As for the atomic mass or the mass number, the bigger number, it is the number of protons plus the number of neutrons. Why do you add the protons and the neutrons together? Because this is the mass of the atom. Atomic mass, the mass of the atom. Oh, why don't we count the electron as part of the mass of the atom? Because the electron's mass is negligible. It's almost nothing. And for the chemistry buffs out there, what is the mass of the electron? If you know the answer, comment below. We can write it here, the small number above, the big number below, or you can write it like this. This is the symbol, and on the left side, there is a smaller number downstairs and a bigger number upstairs. This is the atomic number. This is the atomic mass or the mass number. Here is a practice question for you. Here is a symbol for an element. Here is a number and another number. From this, can you deduce the number of protons, the number of electrons, the number of neutrons, and the mass of one atom of Zr in AMU units, atomic mass units? If you know the answer to this question, please comment below. Let's talk about carbon. All right, here is carbon. How many protons does the carbon atom have? The answer is 6. How many neutrons? If we say 6, therefore 6 plus 6 is 12. Remember that the mass number is the number of protons, 6, plus the number of neutrons, 6, equals the mass number, 12. So this is also known as carbon 12. So carbon 12 can be written like this. But because the 6 will never change, you can just erase it and imagine that it does not exist. Now, what is carbon 13? It is carbon. It still has 6 protons and therefore 6 electrons, but it has 7 neutrons. Therefore, the mass number is 13. What is carbon 14? Here is carbon, same number of electrons or protons, which is 6. I'm not going to write it. And the neutrons here are 8, because 6 plus 8 equals 14. And we call this carbon 14. What do you call it when you have a bunch of atoms that share the same number of protons, but they differ in the number of neutrons? We call them isotopes. If the isotopes happen to be radioactive, we're going to call them radioactive isotopes. Enters today's topic, the radioactive iodine uptake. The story is easy. You give the patient iodine 131 or iodine 123. Both of them are radioactive. You can administer the radioactive iodine orally or parenterally by means of injection. And then what? This iodine is going to float into the bloodstream. Okay. The iodine is a very important raw material for the thyroid gland, as you know, because we need this iodine in order to make thyroid hormone. The trick is that you give iodine that is radioactive, therefore you can trace it. You can see it, you can check on it, you can follow up with it, you can see it entering into the thyroid gland. And this is called uptake of iodine that is radioactive. And then, just like the good mathematician you are, you create a ratio. In the denominator, we're gonna put the total radioactive iodine that you gave the patient. And in the numerator, you're gonna put how much radioactive iodine entered into the thyroid gland. And this creates a ratio. If you want it to be a percentage, you simply multiply it by 100% to get a percentage. Let's say 20%. And this will be called the radioactive iodine uptake, 20% in this particular case. Is this normal? Yes. We can use radioactive iodine diagnostically, and we can also use it therapeutically. First, we'll talk about it diagnostically. To diagnose what? To diagnose thyroid disease. Radioactive iodine uptake in this particular example is targeting the thyroid gland. It doesn't care It doesn't worry about the hypothalamus or the pituitary. A radioactive tracer, could be iodine 123 or iodine 131, is administered. Both iodine 123 and iodine 131 emit gamma radiation that can be externally detected by the doctor or the technician. Which one do we prefer? It depends. If you want to use it diagnostically, 123 is better. Why is this? Because it has a shorter half-life, meaning it emits less radiation over time. But if your goal is to destroy the thyroid gland, then give the one that has the longer half-life. Moreover, iodine 131 not only emits gamma radiation, but beta radiation as well. After this, you're gonna create your beautiful mathematical ratio with a denominator and a numerator. And this will be called the fractional uptake of the tracer by the thyroid gland divided by everything. We do not use radioactive iodine during pregnancy or during breastfeeding because, well, it's radioactive. Now, what's the difference between alpha radiation, beta radiation, gamma radiation, or alpha decay, beta decay, and gamma decay? I've talked about this topic in great detail in my physics playlist, so let's review. This is the nucleus of the atom. This is the electron cloud. There are two types of reactions that we study. Chemical reactions, see your chemistry textbook, are concerned with what happened to the electrons. I could gain electrons, lose electrons, share electrons, etc. Whereas nuclear reactions are concerned with what's happening to the nucleus of the atom, hence nuclear. Nuclear reactions come in many shapes and forms, including natural, spontaneous nuclear decay, which is the phenomenon of radioactivity, which has three subtypes: alpha, beta, and gamma. Why are we decaying? In order to become more stable. The second law of thermodynamics has entered the chat. Nuclear decay means that the nucleus of the atom breaks apart. As it decays, it's going to give us two or more daughter elements and a form of radiation. Here is the unstable nucleus that is about to decay. If it undergoes alpha decay, it will give us an alpha particle, which is a helium nucleus, with 2 neutrons and 2 protons. If it undergoes beta decay, it's going to give us an electron, which is the beta particle. How about gamma decay? That's just a radiation. This is an electromagnetic wave. Here's the parent nucleus. If it undergoes gamma decay, it will give us this gamma electromagnetic wave. And the nucleus is going to become more stable after that. Now you understand what gamma radiation means. After the radioactive iodine tracer is administered, only 2 main organs can clear the radioactive iodine from your body. Number 1, the thyroid gland. Number 2, your kidneys. As the kidney clears your iodine, the iodine level in the plasma will decline. And of course, I'm referring to the radioactive iodine. It declines over time. Where is it going? It's leaving the body and it's going to the thyroid gland. So in the thyroid, the radioactive iodine concentration is increasing and increasing and increasing. Exponential decay, exponential increase. Exponential decay in the plasma, exponential rise in the thyroid gland. Then we calculate the fractional uptake, the radioactive iodine uptake at the plateau equals thyroid on top divided by everything. What do you mean by everything? The 2 organs that can clear the radioactive iodine, which are the thyroid and the kidney. Here's the numerator, here's the denominator. If you multiply by 100%, you convert the fraction into a percentage. For example, suppose that the clearance of the radioactive iodine by the thyroid happens at a rate of 0.4 liters per hour. I'm going to put this number here and here for the thyroid, plus the rate of clearance of radioactive iodine by the kidney, which is about 2 liters per hour. And then you do the math. The radioactive iodine uptake, or the fractional uptake, is 16.7% by the thyroid gland. The normal range, or the reference range, is between 5 and 25. Now let's talk about radioactive iodine uptake in different thyroid conditions. If my thyroid gland is normal, therefore the radioactive iodine uptake will also be normal. What if I have Graves' disease, which is hyperthyroidism? The thyroid gland is too active, so the radioactive iodine is going to be increased. This thyroid will also be diffusely enlarged. How about toxic multinodular goiter? It depends. It could be normal or it could be increased. This gland is not uniformly enlarged as in Graves', but rather it is nodular, with parts hyperactive and other parts normal or hypoactive. How about a toxic adenoma, which is a benign tumor? Why do we call it toxic? Because it could be hypersecreting. That's why it's called toxic. How about thyrotropic adenoma? Thyrotropic, grow the thyroid. Yes, the radioactive iodine will be high. What if the thyroid gland is normal, but I am taking excessive thyroid hormone from the outside, exogenously? What's going to happen? Well, the thyroid gland is not doing anything. In fact, the thyroid will say, hey, you're getting your thyroid from outside. I'm going to make less now. Therefore, the radioactive iodine uptake will diminish. Your adrenal gland behaves in the same manner if you take glucocorticoids from outside. How about in subacute granulomatous, also known as ducal vein thyroiditis? The activity of the gland is minimal, so radioactive iodine uptake is usually diminished. How about hypothyroidism? Of course, it's going to be low. Pause and review. We have just finished talking about radioactive iodine uptake diagnostically. Now let's use it therapeutically. This is known as radioactive iodine ablation. What disease are we trying to treat? This can treat Graves' disease or hyperthyroidism in general, toxic multinodular goiter, thyroid cancer sometimes, and pituitary adenoma. How does it work? By destroying and annihilating your thyroid tissue. This causes death of thyroid cells and decreased thyroid size and function. However, 1 year after the radioactive iodine ablation, the thyroid size is usually restored. What are the pros and cons of this therapy? Pros, it can treat hyperthyroidism and sometimes thyroid cancer. But if you destroy your thyroid, guess what? You can suffer from hypothyroidism. Tell me more about the complications of radioactive iodine ablation. First, I started with hyperthyroidism because I had a disease. Then after the ablation, I became normal and then hypothyroid. Radiation thyroiditis. This is a tender gland that is inflamed and can lead to thyrotoxicosis, also known as thyroid storm. I have a video on this topic in my endocrinology playlist. Lymphocytic infiltration of the thyroid gland. And if I have Graves' disease, radioactive iodine ablation might worsen the orbitopathy symptoms of Graves'. These are the symptoms or the diseases that affect the orbit in cases of Graves' disease. And in rare cases, radioactive iodine can introduce thyroid cancer. Again, do not use radioactive iodine during pregnancy or lactation. Suppose that I have hyperthyroidism. The medications have failed to treat me. So the doctor gave me radioactive iodine ablation. Then what? The doctor is going to give me thyroid hormone, usually levothyroxine. How does the doctor know whether I am doing well or not? How do you follow up with the patient? By measuring the TSH mainly. Because if the TSH level in the blood is normal, this tells you that the thyroid gland is usually normal, neither under-secreting nor over-secreting. Because let me tell you, whether I have primary hypothyroidism, secondary hypothyroidism, or tertiary hypothyroidism, the TSH is not normal. Whether I have primary hyper, secondary hyper, or tertiary hyperthyroidism, the TSH is still not normal. So if the TSH is normal, the thyroid gland is normal. So the doctor is going to give me T4 or T3 and then follow up with me using what? Using the TSH level. How do you know? Well, if the TSH is lower than normal, what does that tell you? It tells you that the level of T4 is too much, to the point that the anterior pituitary had to lower its TSH via negative feedback. Therefore, what should you do if you realize that you're giving too much T4? You should lower the dose of T4. What if the TSH is high? What does that tell me? It tells me that the T4 that I'm giving is not enough, which forced the anterior pituitary to make more TSH. And if I'm giving too little, therefore I need to raise the dose of T4. So we monitor the level of T4 by means of TSH level in the blood. Do you want to learn about thyroid surgery, general surgery, orthopedic surgery, trauma surgery, cardiothoracic surgery, vascular surgery, neurosurgery, and more? Download my surgery high yields course at medicosisperfectionalis.com. To learn more about T3 and T4, the different types of insulin, how to calculate the dose of insulin, download my endocrine pharmacology course at medicosisperfectionalis.com. And to learn about all the drama that takes place in your kidney's proximal tubule, loop of Henle, distal tubule, and collecting ducts, download my kidney physiology course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. And don't forget to say thank you to this kind gentleman. There are more than 700 premium videos available on this channel. When you click the join button and choose the highest tier, please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, and Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.